everybody, and welcome to another episode of The Patient Pulse. It's my pleasure to welcome David DeiCicchi, who's going to discuss non-medical switching, which is an issue that affects many patients on anticoagulation. David is a pharmacist and a board-certified anticoagulation care provider. He currently serves as the director of the Anticoagulation Management Service at Atrius Health, which is a large multi-site ambulatory care organization in Massachusetts. So welcome, David, and take it away.
Well, thank you very much for the introduction, and I'll jump right into it. So what we're going to talk about today is really more specifically, we're going to discuss the issue of non-medical switching that recently occurred with apixaban, which is brand name Eliquis. We're going to review the different ways insurers and pharmacy benefit managers can influence prescription formularies. We're going to describe the impact that has on patients and even clinicians. And we're going to outline some strategies for patients to really combat non-medical switching as well. And the reason why we're here today is because 150,000 patients got this letter from CVS Caremark. And I know that we think of CVS Caremark as either a retail pharmacy or even a mail order pharmacy, but they're much more than that. In this particular case, they're actually acting almost like a health insurance company. It's called a PBM, or a pharmacy benefits manager. So they're the ones that dictate what's on a formulary. And a formulary is just a group of medications that are covered by insurance versus ones that are not, would be non-formulary. And they also may dictate the insurance coverages for other health insurance companies or the government insurance, for example, or even an employer. So these PBMs, or pharmacy benefit managers, really can dictate sometimes what you can and can't take for medications, which is unfortunate. And in this letter, you can see here that they're writing to inform their patient that starting in January 2022, certain prescriptions that they've filled in the past are no longer going to be covered by their pharmacy benefit plan. And this next sentence is really telling. They're saying that we're here to help your provider choose a new covered medication. And remember, this is almost like an insurance company that's telling you that they're going to help your provider choose the prescription for them. And there's no physician or patient relationship here. This is your insurance company. They don't know the details of your case. They've never examined you, for example. And you can see here at the bottom that if you choose to continue on the uncovered medication that's no longer on their formulary, they're saying, then you will have to pay 100% of the cost of the medication. In this particular case, the medication was Eliquis, which is the brand name for apixaban. And that medication can cost upwards of $700 or more a month. So where patients can't afford that, they're forced to switch to the health insurance's alternative, which in this case was warfarin, or brand name Xarelto, which is the brand name for rivaroxaban. Warfarin is an older anticoagulant, and it poses a lot of issues for patients. It's not very practical. You have to get your blood monitored. And Xarelto, which is, again, the brand name for rivaroxaban, is a direct oral anticoagulant, just like Eliquis. So they're very similar for all intents and purposes. But as a prescriber and a specialist, I know that the decision between using Eliquis and Xarelto is very nuanced. And for some patients, I prefer to prescribe Eliquis, and for others, I prefer to prescribe Xarelto. And this letter is basically saying that they're taking that decision out of my hand. And really, it's a shared decision with the patient. So they're taking that decision out of the patient's hand as well. And they're forcing us to prescribe one of the covered alternatives. So as I just described a situation of non-medical switching, we can now define it. Non-medical switching is when a health insurer or a pharmacy benefit manager like CVS Caremark switches a patient's medication to a different medication for non-medical reasons. And the reasons that they're switching it is really to increase profits for themselves, or to reduce the cost for their client, which may be the government's insurance or maybe an employer. And sometimes there's even an agreement between the payer and a particular drug manufacturer. And what will happen is these drug companies will approach the insurance company and they'll say, hey, we can give you our medication for a little bit cheaper cost, but we want to bundle in these other medications that we make as well. And we want you to prefer them on your formulary over our competitors' medications. And this is a practice that happens quite commonly. It's not very transparent either. So this isn't public information. This is really behind the scenes between the drug manufacturer and the insurance company. So this isn't a new practice either. These third-party or insurance companies have really been forcing non-medical switches by manipulating medication formularies for many years. And they can do this using a lot of different tactics. And it's really important as the patient and the provider to make sure that we understand these tactics so that we can help combat them. So, for example, you might recognize prior authorizations when you go to the pharmacy and the pharmacist tells you that the insurance is requiring a prior authorization before we can cover your medication. What that means is the prescriber has to prove that you as the patient needs this medication over something that they'd rather them prescribe. And that can be a very time-consuming process for both the prescriber and the patient and causes significant delays in their care as well. They can also change the coverage of their medication to a higher tier. So within these formularies, these covered medications, they also have different tiers. So low tier medication, like a tier 1 or 2 medication, can be a very cheap generic drug. And when you get to the register at the pharmacy, you don't pay a very high copay for it. Whereas a tier 3 or 4 medication can be a very expensive drug. And when you get to the pharmacy register, you'll pay a lot higher price or higher copay for those medications. So by moving it up a tier, they'll really discourage you from wanting to stay on that medication because it's a higher cost month after month. They can also enact step therapy. And step therapy means that the health insurance company is going to force you to use something at step 1 before you're allowed to use something maybe more expensive or that may work better or be safer at step 2 or step 3. They can also block manufacturer copay cards, which really physicians and patients rely on to be able to afford their copays every month at the pharmacy. And they can increase patient out-of-pocket costs in other ways as well. For example, they can add a high deductible to their plan. And these high deductibles often will target high-cost medications like tier 3 or 4 medications. So when you go to the pharmacy in January, every year you have to pay the deductible, so that first prescription might cost you $500 before you get down to the usual copay in the preceding months. Or, like in the case of apixaban, they can completely exclude the medication from the formulary altogether. And for you to continue on that medication, you'd have to pay 100% of the cost of the medication or switch to their alternative. So what's the actual impact on patient care when non-medical switching occurs? 68% of those who have been a part of non-medical switching had to try multiple medications before finding one that worked again. 48% of patients had to actually switch to something that they previously used but discontinued because of a lot of side effects or that it just wasn't effective enough. So they're settling for something that they know isn't perfect for them. 95% of patients reported that their symptoms became worse, meaning they had reemergent symptoms from the disease state. The disease state wasn't completely covered or treated, and they were having more problems with that. 58% reported being switched to a medication that caused more side effects than the original medication that they were on. And maybe most importantly, 9% of patients actually had to be hospitalized because they were switched to another medication and was really forced by their insurance company or a pharmacy benefits manager. And you can see all the negative impact it has on patient care, including quality of life, but it also probably increases costs for the insurance company. So it's counterproductive for them as well, which is unfortunate. So how do we combat this? Well, again, it's really important to understand what the problem is so that you can attack it specifically. So for prior authorizations, for example, is a situation where the prescriber has to write an authorization for the medication to be covered. And in this particular case, if it gets denied, they can actually go through an appeal process where they can do a peer-to-peer appeal process where they're talking to another physician and reviewing the case and deciding whether or not it gets covered through the prior authorization. And it can even go through an external appeal process where the peer-to-peer person is not someone that works for the insurance company. If it's a step therapy issue, where you have to try one medication before you can step up to what the prescriber wanted you to be on or what you wanted to be on. It's a matter of just trying that medication first, proving that there's some type of intolerance or it didn't work well enough for you, and then being able to go on to the medication that was originally preferred. Or the doctor has to prove that there is some type of reason why you can't use that first step, in that you have to skip right to the medication that they're preferring. So these can be time-consuming processes for the physicians, and it can be a lot of follow-up work for the patients, but they're very successful processes, and a lot of them end up getting approved after you go through the process. If you have a medication that actually gets moved to a higher tier, or maybe it's higher tier than some of the alternatives, there's a process you can go through called a tier exception application. And what that will do is when you go to the pharmacy, you'll pay the cost of the copay of the lower tier, the cheaper medication, instead of the higher cost medication, as long as your prescription or your provider, your prescriber can actually prove that you can't be on the lower tier medication for a medical reason. Or the problem in this particular case where apixaban was just taken off the formulary, it was just excluded from the formulary. There is no real precise or exact way or a solution for that through the insurance company, and we have to take further steps and go above the insurance company. So a lot of people were voicing their concerns in this particular case to the Federal Trade Commission. They were writing their state representatives about the problem because state representatives can actually put in place laws that regulate these insurance companies and pharmacy benefits managers to eliminate these unfair practices. And really, you have to use the power of numbers. All right. So you have to go through advocacy groups and nonprofit groups like NATF and let them fight this battle for you. In the case of apixaban, there were petitions that were created and letters were sent to CVS Caremark and the insurance companies and pharmacy benefit managers or employers. And patients were considering switching off their prescription insurance in favor of another prescription insurance, which can be, a dangerous practice because you don't want a lapse in your prescription insurance, and you have to find the right one for you still. And you don't always have the option as well to switch. But these practices definitely work. In fact, we were able to overturn the exclusion from Caremark's formulary. And as of July 1st, 2022, it's going to be back on the formulary for CVS Caremark. So those 150,000 patients that got that letter saying that they no longer use Eliquis are going to be able to use Eliquis again. And it was really because of the unprecedented outpouring of patients, clinicians, nonprofits, and everyone that helped fight this battle to really allow Eliquis to be on the formulary because of how important it is to patient care. And this reversal is really a testament of that power, that collective action power that they were able to do through patients and organizations like NATF. So I think in this particular case, we're really fortunate that Eliquis is such a popular medication. There's so many patients on Eliquis that we had power in numbers with this case, and we were able to get it reversed. So what I'd like you to take away from this presentation is that although prescription insurance is essential for patient care, it's almost impossible to manage disease states for patients without any prescription insurance. Some of these practices that these pharmacy benefit managers and insurance companies are using can be a little bit unethical or deceptive. Understanding your prescription insurance can help you combat non-medical switching. You have to understand why it's a high out-of-pocket cost in order for you to start to look for a solution, as we discussed. And you have to be really resourceful. And that could mean multiple different things. Hospitals and primary care organizations, they have caseworkers and social workers to help you through these processes. You just have to use them. And there's a lot of other solutions out there as well, like nonprofits and advocacy groups that can really help connect you to the right process that will work for you, or even help just decrease high cost drugs. And that's a completely separate presentation for another time, but there's a lot of resources to help combat high drug costs as well that you could take advantage of that a lot of patients don't. So with that, I'll conclude, but I want to also thank NATF for giving me this platform to help you through these insurance issues that are very common. And I want to thank you for listening.
And thank you so much. That was such a great presentation. I think it'll be very useful to help patients navigate insurance issues. So we really appreciate your time and expertise. And to all of our listeners, join us again next month for a new episode of Patient Pulse. Thank you.